Great. Good morning, everyone. Good afternoon. Well, thank you for joining us. My name is Lara Vaz. I am the Technical Director with Momentum Knowledge Accelerator and the Population Reference Bureau, and I am pleased to be moderating this session on child survival action and our work on a results framework for advocacy and action. And just a couple of technical points for there is interpretation available. So if you go to the bottom of your screen, there is a little icon in the middle of your on the menu for interpretation. If you click on that, you will be able to choose between English and French. Il y a d'interprétation disponible en français. Il faut aller au bout de votre écran pour choisir la langue. With that, I am happy to introduce Dinesh Kasangami, who will continue with the session today. Just an overview, next slide, please. We will be running through an introduction of the CSA as well as the framework, the results framework, have a little moment for questions and answers, and then go into more detail on the results framework and the next steps with an additional opportunity for questions and wrap up at that time. If you have questions, please feel free to be putting them into the chat, and we will be monitoring that for you. Thank you. Dinesh, please go ahead.
Thank you, Lara. And I'm pleased to be part of this presentation to talk about the child survival action, what it is, and how we plan to work together. So I'll start with what brings us together. The child survival action brings partners together because 54 countries need accelerated action to meet the child survival sustainable development goal by 2030. And if you look at this map, in 2030, most of the countries would have achieved the mortality target of 25 or fewer deaths per 100,000 births, except for most of the countries in Africa, where 80% are way off track. And you will see that West and Central Africa have that deep red and orange, which means some of these countries will still have as high as 75 deaths per 1,000 live births. These are also countries facing fragility or humanitarian contexts. And so the child survival action focuses on Africa, where we need action that will change the trajectory of under 5 mortality. Next slide, please. This graph shows us that across the 54 countries that are not on track to achieving the SDG target, a significant proportion of the deaths are after the neonatal period. And what this means, we'll be talking about it later, is that to reduce mortality, we need to focus on that 1 to 59-month period, as well as the first 28 days of life. Next slide, please. So then we ask, what is killing children in these 54 countries? And this analysis shows that pneumonia, diarrhea, and malaria were endemic remain the leading causes of death in these countries. And we know that we have effective, cost-effective interventions to prevent and to treat these conditions. But children continue to die because they lack access to these interventions. Next slide. What do these data show us? Just repeating that the continued high mortality after the neonatal period from common infections is an expression of increasing inequities. And that is why, in part, this conference focuses on addressing inequities. It also points to multiple deprivations that these children face. On one hand, is the malfunctioning of the health system at primary healthcare level and the failure to access the integrated services. We know that in these countries, integrated management of childhood illness, IMCI, has been introduced and scaled up, but coverage remains unequal, and there are huge, and I repeat, huge quality gaps. Similarly, in integrated community case management has not been institutionalized in many of these countries to reach children with limited access to facility-based care. Referral systems and referral care remain suboptimal. And on the other hand is an accumulation of risk factors: poverty, food insecurity, lack of access to clean water, sanitation, air pollution, and fragile and humanitarian contexts, as I already observed. Next slide. So then, in framing the child survival action, there are 5 key messages or the focus, with the goal of ending preventable deaths in the 1 to 59 months of age. And I will explain why the focus is on 1 to 59 months of age. But the key messages, first, are focusing on the 54 countries and focusing on Africa, as we saw on the map. That's where the need is greatest. Number 2 is reaching the children that are being left behind, meaning they are not accessing the effective interventions against pneumonia, diarrhea, malaria. We also know that undernutrition is a big contributor to mortality in these children. Thirdly, we emphasize strengthening primary health care in the facilities and at the community level to effectively prevent, diagnose, and treat these conditions. Building effective partnerships, and lastly, mobilizing required resources from both domestic and international sources, and including the private sector, to deliver on this renewed vision. Next slide. So again, the child survival action aims to end preventable deaths. But we need to think about it as part of the continuum. So the focus on the 1 to 59 months of age builds on the ending preventable maternal mortality and the Every Newborn Action Plan to focus on the infancy and childhood periods. And unless we see the action as part of the continuum, we are not going to achieve our target. Another element of action is aligning with other sectors and programs that are addressing the needs of these children. So, for example, immunization, and there's emphasis on the zero-dose children, and these are children that are also not accessing these treatment services we are talking about. It's also addressing the nutrition and food security needs, malaria, and so aligning across the different programs and sectors is an important component of the child survival action. Next slide. Okay. So what are the strategies of the child survival action? Or asked differently, what will be different this time round? Since we've said we know the solutions, but we are still failing to reach these children. First, at the country level, it's emphasizing political leadership and accountability. It is also focusing on game-changing action, which means each country needs to look at the data as I have just presented in terms of the leading causes of mortality, but it's also the children that are not being reached. It is the resources that are available, and it is using data to decide what these game-changing actions will be. And it is also alignment of all the partners in support of government-led priorities. Key principles, just rehashing what I already said in the key messages, emphasizing people-centered and quality primary health care, delivering high-impact prevention, promotion, and treatment. Accountability at all levels for change. Again, emphasizing the need for data that will show us where we are doing well and where we are not doing well and what we need to do from the community, subnational level to the national level and the global level. It is multi-sectoral responses that align with national strategies and plans. Again, when we talked about the multiple risk factors, some of those will be addressed outside the health sector: clean water, sanitation, air pollution, food security. Meaningful engagement of communities as users of services, but also as citizens demanding accountability, particularly from the political leadership, that will be important in achieving the targets of the child survival action. And lastly, it's an equity-sensitive approach, as we are discussing in this conference, reaching the children that are being left behind. The child survival action has been organized under 3 action teams in terms of driving action. So it's a country engagement. There is the results and accountability framework, which is the action team hosting this presentation. And then there is an action team that will focus on advocacy. But in essence, really these action teams will need to work together and to bring together the partners at the country level in order to achieve the goal of the child survival action. I think this ends the introduction, and I'll hand over to Kate Gilroy.
Thanks so much, Diness. My name is Kate Gilroy, and I'm a co-chair of the Child Health Task Force M&E subgroup, along with Deborah Jackson, who's on vacation this week, as well as a co-chair of the Child Survival Action Metrics group. I work at JSI and on the Momentum Knowledge Accelerator and the Momentum Integrated Health Resilience. And I'm going to do an overview of kind of some of the steps in the development of the Child Survival Action Results Framework. Next slide. So I believe the title of this session is the Child Survival Results Framework for Action, for Advocacy and Action. And so just wanted to kind of talk about why are we doing a results framework for this initiative that Diness just gave a nice overview of. And it is really to advocate, probably using more the impact and coverage indicators to raise awareness and mobilize resources at both the global and country levels. And then, action as far as engaging and coordinating with partners and countries to collectively work towards some common goals. So the results framework, is a kind of roadmap of some of those common goals. And then to plan programming, inform resource allocation, and certainly to track or monitor implementation of the actions. Next slide. So the child survival action started out with a theory of change. I see some of the folks who were involved in that more than myself even are on the line. The action teams, or the child survival action group, worked on a theory of change, and starting with the light blue all the way to the right-hand side, you'll see the goal, as Diness mentioned, is accelerated reductions in under 5 mortality in these 54 countries that are lagging behind. So mortality is really the overall goal. And then in teal, you'll see the outcomes, moving one box back, is strengthening primary health care and this focus on equity and equity gaps eliminated and universal health coverage achieved. And then some of the outputs that are hypothesized to get to the outcomes are in the purple box, and it's really national and subnational plans, sharpened, costed, budgeted, and implemented, and as well as political and financial commitments, and then informed and effective health leadership and management. And I should note that the health, in the much more detailed narrative or theory of change, that's where kind of health systems and health system strengthening sits as well. And then in the first box on your right, the last box if we're moving from the left, the strategies are in the indigo box, and it's really, focusing on data, public and private partnerships, community engagement, quality of care, and then accountability and tracking of progress. And then in the purple box, kind of what Diness mentioned, some of these guiding principles are survive and thrive, leave no child behind, family and child-centered care, whole of government action, and accountability. And so this is kind of the layout or the vision for the child survival action. And if we go to the next slide, because we're measurement folks, we wanted to build on this and put a little bit more of a linear log frame on it. And so, you'll just see a standard log frame from structures or inputs to processes, outputs, outcomes, and impact. And then what's below is kind of mapped to what we're going to talk about today as far as some of the results or indicators that we've been working on, and kind of how we're moving forward with this results framework. Next slide. So as Diness mentioned, the child survival action really does build on a lot of other initiatives and leverages and wants to harmonize with a lot of these other initiatives. And, I put this back up because it is really kind of, in the continuum of care, pulling this out that the child survival action is covering these later periods in the continuum of care, in the life course approach. And so what we decided is to follow the approaches that every newborn action plan and ending preventable maternal mortality have followed as far as putting their global frameworks together. So for these earlier ones, the structures, processes, and outputs, really looking at implementation milestones and perhaps country-specific implementation indicators. And then for the outcomes and impact, looking at a limited number of validated indicators. Okay, I will speak more slowly. Next slide. So as I mentioned, some of these principles kind of been mentioned before, but building on other global tracking initiatives, such as the Sustainable Development Goals, the Countdown to 2030, child health and well-being dashboards, as well as others that are out there that are already really looking at child health, perhaps more broadly, and pulling out those, highlighting and advocating for the child survival pieces of those, rather than recreating or duplicating what already exists in the world. Another principle is really to leverage existing data in countries to reduce data collection and reporting burden. There have been discussions with countries through different venues, and they're not surprisingly, countries have a limited appetite for more global plans, for more global reporting requirements, for more data collection when there's already a lot of data collection and reporting going on. So, obviously going back to one of Dinessa's slides, focusing on the main causes of mortality in this age group of children 1 to 59 months in the 54 countries off track. So we saw in Dinessa's slide that the direct causes are malaria, pneumonia, and diarrhea, malaria where it's endemic. Underlying causes or risk factors, certainly nutrition. And then there are definitely contextual factors that contribute to mortality. And some of those we can measure, some of them are more difficult to measure. But we have been discussing that. And as I mentioned before, really selecting validated indicators. And we started with the Child Health Accountability and Tracking Technical Advisory Group, did a large review of indicators for child health, and suggested a number of them, and really did this big mapping and had recommendations. And these are all aligned to the WHO Observatory and other global indicators, and that those are mostly more for impact and coverage, and we'll see that in Jennifer and then a bit in Shane's slides. Next slide. So we did start too by mapping some of these global recommendations and initiatives to the theory of change. And you'll see on the right-hand box some of the initiatives we mapped. So it goes beyond kind of some of the ones I mentioned earlier, and I think the slides will be shared. Those are all the links. So it's not a bad list to have all the links of those in one place. And then, as I mentioned, we selected these from chat. We've been working as a metrics group to look at these, vet these, also have been working with, as Dinessa mentioned, there's a country engagement group or a broader child survival action working group to vet these. And then we also, for the impact and coverage indicators, also consulted external technical groups such as the MERG, or the Malaria Epidemiology Reference Group for malaria, the Joint Monitoring something for WASH, Team and Data Dent for nutrition, WUNEC for immunization. So really, we worked together to select what we thought was important for this initiative for, child survival in these countries, but then also reached out to some of these other groups who do much more metrics work within a immunization or within nutrition, to make sure that the definitions or the very detailed details of the indicators we were selecting made sense, or what's being used globally, and also are the best ones that would lead to child survival. And we're not going to go into all those indicator nuances in today's presentation, but we did do a lot of discussion about those nuances. And then Shane's going to talk about the implementation milestones and indicators, and he'll talk about we proposed domains based on, again, the ENAP EPMM framework and mapped it to the theory of change and other global frameworks, as well as implementation bottlenecks that were identified in Sierra Leone by the Child Survival Action Country Engagement Team, working with the Sierra Leone Ministry of Health on their Child Survival Action plan, or I'm not sure the exact name of it. But as I think Laura mentioned at the top, this is all kind of a work in progress, especially on the implementation milestones and indicators. We are closer on the impact and outcome indicators to finalization, but we're continuing the iteration, gathering feedback. That's why we're happy to be presenting here, and one would like your feedback, especially on some of the implementation milestones. Engaging with countries, we've been talking, how best to engage with countries and through the country engagement team to get feedback on these, what is useful. And then obviously, there are lots of revisions and finalization. So I think with that, the next slide is actually, I'm going to turn it over to Laura. I have not seen any questions in the chat, and I don't think we have an enormous group. So maybe if anyone wants to come off mute and ask a question, or please feel free to type in the chat. And there will be a question section later on as well, but wanted to stop here because unfortunately we're losing Diness as well to the larger, the plenary closing in a few minutes. So wanted to stop here and see if there are any questions. Over.
Thank you very much, Kate. Just to add, pour les francophones, si vous voulez partager vos questions en français, on peut les répondre soit en français ou soit en anglais. So happy to hear comments, questions before we move ahead. And feel free to come off of mute. As Kate has said, we are a small group. Thank you, Thomas. If there are no questions or comments right now, please feel we may continue, but we would be happy to come back to some questions as related to these first two sections of today's session as we proceed into the presentations around our overview of the indicators, the introduction to the milestones, and some next steps. With that, I am going to pass the microphone on to Jennifer Acacia.
Thank you so much, Laura, and I'm very pleased to be with you all today to present to you the impact and outcome indicators from the Child Survival Action Results Framework. My name is Jennifer Acacia, and I am currently based at Johns Hopkins University and also at the Global Financing Facility for Women, Children, Adolescents Health at the World Bank. Next slide, please. So as Kate and Diness have already explained to you, there has been an extensive consultation process around coming up with a core small set of indicators for tracking more at the global level, and especially for advocacy purposes. This has engaged a few steps, as has already been outlined, around mapping existing global initiatives, consulting with the Child Health Accountability Tracking Working Group, and doing additional consultations with the expert groups in each of the domain areas that I will describe in more detail to you in just a minute. So on this slide, what you're seeing here are the 4 impact indicators that have risen to the top for inclusion in our framework of core set of indicators. So these 4 impact indicators are organized into 2 areas. So one is obviously the bottom line of mortality. What we have here are 2 indicators. One is really specific to the age group of interest for the Child Survival Action, and that is children aged 1 to 59 months. And then we also, of course, have retained the under 5 mortality indicator. And then over on the other side, you see that we have 2 indicators for nutritional status. And this is related to the fact that undernutrition has been linked with around 45% of all child deaths. So it's really critical to keep a good eye on how well countries are doing in reducing both wasting, which is a form of acute malnutrition, and stunting, which has more of a chronic undernutrition. It gives a little bit more of a marker of that. And we are both tracking both moderate and severe levels of wasting and stunting. Next slide, please. So here you see, again, kind of going back to some of the earlier slides that try to show you how all of this is fitting into this child survival action as a whole. So you see that what we're talking about when we're thinking around this core set of impact and outcome indicators is nesting this within the theory, the child survival action theory of change, and then showing how the results framework builds logically into the theory of change so that as we're moving along, that the progress that we're monitoring can be related back to the theory of change and to test that theory of change. So when it comes to the outcome indicators, you can see it's right in the center there of the results framework. And what we're talking about when we think about the outcome category are these 3 interlinked dimensions of intervention coverage, the quality of the interventions that are delivered, and then of course that principle of equity, because without achieving or reaching all children, we won't be able to progress towards the SDG targets. Within the outcome area, covering these 3 aspects of coverage, quality, and equity, we've agreed upon these 3 major bucket areas. So this is again nutrition, because this will clearly has a logical link to those impact measures that I mentioned of wasting and stunting. Then there's the illness prevention, and then illness management, which we've included here, the issues of diagnosis and treatment. Also, another key principle here is that we wanted to be sure that as we're thinking about the leading killers of children, that these outcome measures allow us to track progress in addressing those leading killers of children, both through a prevention and a treatment lens, and then also as well, both taking into consideration care-seeking or demand side factors, as well as supply side in the sense of what the health system is able to deliver. Next slide, please. So with that being said, I'm going to dive into each one of those 3 domain areas that you saw on the previous slide to give you a sense of where we've landed after additional consultations with the expert groups in each one of these domain areas. So for nutrition, what you see here are 3 sentinel indicators that are really tied to child survival. First is exclusive breastfeeding. The second is minimum dietary diversity. And the third is around vitamin A supplementation. For illness prevention, you can see that what we're showing here are a grouping of immunization indicators, plus then of course the ITN use, which would be a cornerstone preventative intervention for malaria. We've really worked hard with the immunization community to ensure that this list of immunization indicators is consistent with the IA 2030 framework and also with what WHO and UNICEF track on an annual basis in terms of progress on immunization coverage. So for immunization, you see, and also to clarify that these are also consistent with the SDG target that's around full immunization coverage. So what you see here is DTP3, measles, second dose, pneumonia, pneumococcal vaccine. And then for 0 dose, we've agreed upon 2 ways in which we want to present that information. We're picking first dose of DTP to, again, make sure that the directionality is consistent with the other indicators. And then also showing something around the absolute number of 0 dose children as a clear advocacy message. We also are tracking rotavirus coverage, and just to flag here that both the pneumonia and the rotavirus vaccines are here to go back to what was said earlier around pneumonia and diarrhea being leading causes of deaths in this age group of 1 month to 59 months of age. Then going over to the illness management, again, you can see this whole progression that we were talking about that I mentioned earlier around trying to have a preventative as well as a treatment indicator for each of these leading causes of child deaths. So here for treatment, we have diarrhea treatment with oral rehydration salt solution and zinc. And then we are examining in a little bit more detail the best treatment indicator for malaria, given also concerns around resistance. So we want to make sure that what we're tracking is that children that really need the anti-malarial are receiving them. On that note, there was also a framing before that Dianus provided that we're also really interested in examining correct diagnosis, which is linked to quality of care. So here you see that what's risen to the top for diagnostic use is the malaria diagnostic use. Then we also, as I mentioned, to capture something around demand side, we have the care seeking for symptoms of ARI, and then also care seeking for fever. You can see on the bottom, again, sort of in bold, the whole principle of equity underlies all of this work. So the emphasis here will be when these indicators are presented, that there'll be a concerted effort to disaggregate them by stratifiers as relevant and as data is available. So key factors like rich and poor and urban rural and other kinds of factors like that. Next slide, please. So this is just to also indicate 2 issues. One is you'll see on the one hand side that there's a clear need to make sure that we are also monitoring core determinants of child survival. So in that sense, WASH is so key to child survival that it would be remiss if we weren't tracking it. So here you can see 3 of the indicators from WASH around the drinking water, around basic hygiene, and around sanitation. So similar to that, now this other discussion on the other side is around quality of care. If you remember that the very first slide showed that what we really are interested in examining is both intervention coverage levels, equity, and then this whole concept of quality, because if those interventions are not delivered with a high level of quality, then the recipient isn't going to receive the health benefit from that intervention. The issue with having quality of care indicators percolate into a global set are the challenges that are presented on this slide. First is what we are thinking we will do is for each one of these indicators that we have selected, we'll provide some guidance around the pediatric quality of care standard indicators that could be tracked to assess the quality of the intervention delivered. It's also then part of what we would like to include as the initiative's learning agenda to try and work on improving validated and comparable measures of quality of care so that there can be some comparisons drawn across countries in terms of progress. And then also it's just then within that learning agenda, maybe focusing in on particular gap areas in terms of measurement of quality of care. And that might be around pneumonia treatment and management of other infections. So I think that's a close for my session. Next slide, please. Yes, so thank you very much. I am now going to hand over to Dr. Shane Kahn, who is going to present to you where we are with the implementation milestones and indicators. Thank you so much. Over to you, Shane.
Thanks a lot, Jennifer. I am Shane Khan. I'm a global measurement expert. I work with the CSA metrics group and I provide technical coordination of the work that they do. What I'm going to present now is on implementation milestones and indicators. Can we move to the next slide? So Jennifer started off by presenting what's on the right-hand side of this slide on the outcome measures and the goals, the large-scale impacts that CSA is looking to achieve. And those are typically population-based estimates that you get from large-scale surveys like mixed DHS, household surveys, routine systems as well. We'll be able to measure many of these things, and that's at a high level. What I'm going to talk about now are the things that help produce those outcomes and those impacts. So I'll talk about the structures and inputs, the processes, and the outputs overall. These are things that are typically related to program monitoring and program implementation. You have a program in country and you have to monitor it over time. You have to implement and you have to see where improvements need to be made. I'll also note that unlike the outcome and impact indicators that Jennifer mentioned, these indicators I'm going to speak about are not as prescriptive. They actually have to be much more country specific. So we expect that countries actually take on the guidance and work on the indicators themselves. And they have to be country specific because many of the programs that countries put in the field have their certain peculiarities to them. So you have to be able to measure that over time. So next slide, let's talk a little bit about how we came up with implementation milestones and where we are with this. Right now, we're at a draft stage of development, so we're not as advanced as the impact and outcome work, which Jennifer mentioned. We first of all did a review of implementation milestones that already exist. We started with ENAP, and we looked at those categories of implementation milestones, and then we harmonized those with our theory of change. And that, of course, brings certain changes to the overall buckets of implementation milestones, which I'll discuss in the next slide. But before we go on to that, once as we had those buckets, we started looking for actual indicators themselves. And there are a number of documents and guidances that already exist that we can use to create, to develop indicators if need be. So here are some of the guidance documents that can be used: the ENAP milestones and results framework, the WHO primary healthcare monitoring framework and indicators score, etc. Now, as one of our main messages in the CSA is to have high coverage, high quality, and to have equity across different dimensions, we continue emphasizing these three dimensions, even in the implementation milestones work. Let's go on to see the implementation milestones. So on the left is the ENAP set of milestone categories. ENAP started out with 6 different milestone categories, and we looked at this. We looked at our theory of change, and we realized that we could actually come up with 5 milestone categories, which are slightly different, but a lot of similarities. So instead of national plans, we've actually expanded that to include national plans with financing, governance, and accountability as well. Quality of care, we felt, needed to also be expanded into something much more encompassing, like service delivery systems, which not only look at quality of care, but also look at modalities of service delivery within a country for different diseases. Investments in health workforce from INAP could also be folded into our first bucket. And our fourth bucket from INAP, community engagement, we more or less have very similar things on our third bucket, community and family engagement, because we felt, again, we're talking about children, we need to emphasize that family link. INAP has the last two buckets of data and then research and innovation. We folded that into a fourth category for CSA on data and evidence, which includes research, which includes innovations, which includes data as well. And we have a novel category on partnerships because we do understand partnerships globally, within country, within the public and private sector have immense value for the work that we do. And due to that, we wanted to highlight that in our milestone categories for implementation. Next slide, please. This slide is showing our initial implementation milestone categories on the left. That's your first column. And the middle and column on the right show priority areas. So if I could take one of these, like data and evidence, that's a broad implementation milestone category, a set of things that you can think about when you're implementing a program to produce the outcomes. So under data and evidence, we have a number of things here. We have countries should be able to come up with a minimum child health data set. They should have institutionalized CRVS. They should have research and development for innovation, prioritized and coordinated research agenda. I want you to note something. These are priority areas here. They're not indicators as yet. They're just areas, priority areas under certain categories. Because the indicators for implementation milestones are going to be somewhat specific to your country, some of these will be applicable to your country. Some of these may not be applicable. And out of the things that are applicable, you may need to prioritize several of them. So when you think about the implementation milestones, think about these as something that you will have to develop, you will have to prioritize, and you will have to track over time. And again, we emphasize coverage, quality, and equity across these indicators. Next slide, please. Now, let's think about how to actually use this. We started off this session today discussing a situation analysis for children. What are the causes of mortality? The direct causes, the indirect causes? Are there programs in place? Are we reaching children? Are we reaching all children with equity, with quality? Those are issues that our first set of indicators are supposed to answer and help you think about. Then we want you to also think about the health system, the socio-political environment. Who are your partners? Do you have available data? Think about your country context. When you analyze your situation overall, you come up with results from this analysis. You come up with challenges, with bottlenecks, with opportunities, and you map those against the areas that we have identified previously, the CSA milestone categories and priority areas. And those are the ones that I showed in the slides before. You prioritize certain categories and certain actions and activities that you think are most important. And then you come up with the implementation milestones and indicators based on that library of online resources. And finally, you develop different targets based on that, different targets. And from country to country, some of these targets and some of these indicators will look the same. They will look the same. But in other indicators, they may look actually quite different. And that's actually a good thing. We expect that because this is supposed to reflect what your programming and what your implementation looks like. Can we go to the next slide? Now, this is, if I had to imagine what this looks like on paper, this is what I would think it looked like. In the first category, these are just, first column, sorry, these are just your priority areas, which we've outlined, and your categories. The second column are the results of your situation analysis overall. Your situation analysis identified certain things. It may not have identified anything in governance, for example, but it may have identified many issues in service delivery. And you would populate the rest of this table based on that overall. And of course, we want to emphasize coverage, quality, and equity. So you look in the library of resources to come up with those indicators and milestones that measure coverage, quality, and equity across all these different areas. If I can go to the next slide, please. So this part of our work is fairly new, and we wanted to ask you, after having seen this, are there any priority areas that we're missing? Here are the broad categories here. Is there anything that stands out to you that is really missing, a really big red flag? You didn't see something that you should see. I'd like you to tell us. And then based on what I've presented here, what kind of guidance do you need for this? How well does this initial set of ideas work for you? Do you need something more? What would work to help you think about implementation, milestones, and indicators? So I'm going to leave the floor open now for that.
Thank you, Shane. Shane, I will note in the comments that Pratik Gupta has mentioned that there is a lot of emphasis on the supply side of evidence, and where in the framework would we include the emphasis on the demand side for evidence? That it would be important to highlight the information needs of key stakeholders at country level, including formats for the evidence, so they can process it for their governance processes.
Okay, that sounds great. I'm thinking about accountability and accountability going both ways, and I think that could be placed in there, possibly under service delivery as well, but I'm going to actually have to think about that one a little bit more. I'm going to open the floor also to my other presenters to chime in on some of these too.
And I think I note that Jennifer has added information about the demand side indicators. I will note, I'm going to pass the mic to Dr. Charles Monsambo, whose hand's raised.
No, thank you very much for the excellent presentation. I'm just commenting on that slide where you were comparing, you're talking about building on NAP milestones, and you looked at the quality of care and say that under CSA, you encompass it as service delivery systems. I'll be happier if under service delivery systems, we put the word quality at the beginning. Otherwise, we're losing that key. Yeah, here. You look at this quality of care, and if you check under CSA milestones, we just put it as a service delivery system. So I'll be happier if the word quality appeared in 2 to say quality service delivery systems. Thank you very much.
Thank you. Well noted. I see something here on the feasibility of indicators in the chat. Any flags in terms of feasibility? Do you anticipate that most indicators will be needed to be collected outside of routine channels? Indeed, I think a lot of this is going to be, they're going to be collected not in an HMIS system. This is going to have to come from a lot of program records, and people who are very intimate with the programs themselves will have to be there in the design of these indicators and the milestones themselves and be able to fill that in. I don't think there are going to be ready systems necessarily to create this, but unlike population-based data in many ways, the collection of this, I think in some ways is somewhat simpler for certain indicators. But I think as these indicators are going to be developed, we'll also have to recommend methods of verification and methods of data collection for these as well.
Yeah, and just to add there, Shane, I think to Shane's point on John's question, I think that's why we are thinking it has to be country specific, because each country will have different data systems, right? So there may be some that could be collected within an HMIS or an HRI, a human resources information system, or a logistics management information system, but that will also depend on those systems and what they have in the country as well. Because I do, yeah, go ahead.
Kathleen Hill here, and many thanks for this really wonderful work that's gone into developing a results framework and also illustrating the linkages to the theory of change. It's wonderful to see this work under progress. I think I have two questions. One is there or has there been any engagement with country stakeholders, both national and subnational level, to really sort of hear their thoughts on this? And the other maybe observation, and I'm not sure, what the best approach is that I think, having watched the EPMM and ENAP, there have been several years of trying to align these frameworks. And I really appreciate the focus on trying to align with ENAP. I wonder, from the perspective of like a district health officer, or district health management team, or even a national, group, national technical working group, whether there may be advantages to really trying to align EPMM, ENAP, and child survival action, to the degree possible. I understand some of the nuances, and I understand that there are different population groups and specific disease entities that are being targeted. But I do think, from the perspective of a country, when we look at like some of the suggested indicator levels, like, for example, a plan developed, funded, et cetera, all of those are also going to be in EPMM and ENAP. And a district manager is not going to be, I think, from their perspective, the more this can be aligned and harmonized with sort of specific indicators for specific, age groups, I think from the point of view of sort of uptake of global metrics frameworks, it may be more useful. So it's just an observation and no easy answer, but for example, the quality of care, I'm not sure that service delivery completely really addresses sort of some of the current discussions around quality of care, which really are beyond service delivery. But anyway, thank you so much for this great work, and I'm sure there will be ongoing conversations. Thank you.
Kathleen, thanks. I know I'm missing questions in the chat that I can't respond to immediately, but just a few things. One is that country engagement is going to be super important for this, because this has so much to do with what's going on the ground, and it's going to be less standardized and prescriptive than the large SDG types of indicators, which we typically work with at the outcome and impact level. So that is coming next, and that is part of the Child Survival Actions work plan for this, because we need to sort of ground truth a lot of this and get feedback on this. And this is really great, the discussion about where does demand fit in for, within our categories, etc. One of the principles that we've been working with at the Child Survival Action is that we don't want to reinvent the wheel for many things. That's the major reason that we've chosen so many of the SDGs.
Jane, I'm going to push you. We are at time. So yeah, so I think we do need to wrap up. It sounds like we have a great conversation and going, but I do think that I hope we have opportunities to continue this conversation in multiple forums, both at global, but also at regional and country level. Shane, do you have anything else?
No, we are going to continue with this work, and we will come out with a global list of a set of indicators and some guidance coming up. Expect that we can work some more with countries on receiving feedback on this work. And all of this is towards an end of greater advocacy and for action at the country and global level. So thank you, everyone.
Great discussion. Thank you very much.
Thank you. And thank you, Dr. Charles, for being here. On to the final plenary.
Thanks all.